Belmont. Welcome to part 3 of pulmonary pharmacology. We'll begin with discussion of a relatively new medication called Daliresp. This medication is a PDE4 inhibitor. It is not a bronchodilator. It is supplied as a once daily pill in dosages from 250 to 500 milligrams. And the PDE4 enzyme is an enzyme that metabolizes CAMP into an inactive state. And CAMP in the lungs is important for bronchodilation. So what Daliresp does is it inhibits PDE4, and this increases the level of CAMP that's available within the lungs. So for Daliresp, the end result in the lungs seems to be an inhibition of recruitment of some pro-inflammatory white blood cells of neutrophils and of eosinophils. And for the patient, what this drug does is it may reduce the frequent exacerbations of COPD. So patients who are on Daliresp need to avoid CYP450 inhibitors such as erythromycin or ketoconazole, or strong inducers such as rifampicin, dilantin, or carbamazepine to maintain a stable blood level of Daliresp. The adverse effects of Daliresp have been pretty marked in clinical experience, and so recently the FDA approved the 250 milligram dose for the first month of treatment in an effort to reduce the adverse effects. The adverse effects include gastrointestinal disorder, such as abdominal pain, dyspepsia, gastritis, and vomiting, increase in infections such as rhinitis, sinusitis, or urinary tract infection, muscle spasms, nervous system disorders included tremor, psychiatric disorders included anxiety, depression, and weight loss was fairly prominent, along with less common effect of angioedema. It was hoped that by starting at a lower dose and accommodating to the medication, that people would be able to tolerate it and raise it to the more effective dose of 500 milligrams a day. Mast cell stabilizers are another anti-inflammatory group of medications used in the treatment of pulmonary disease. These drugs prevent and reduce inflammatory response in the bronchial walls by inhibiting the secretion of mediators from the mast cells. They stabilize the mast cells. Their exact mechanism of how they do this is a little bit unclear, but they appear to act locally to inhibit the release of mediators of the type 1 allergic reactions, importantly including histamine and leukotrienes from sensitized mast cells after they've been exposed to an antigen. So what happens is the mast cell is exposed to the antigen, and ordinarily it contains substances that cause rise in histamine and leukotrienes, and these are pro-inflammatory and pro-allergic substances. So if we stabilize the mast cell so that it doesn't release these when it's sensitized, it prevents that cascade of effects. And so it has both anti-asthmatic effects and anti-allergic effects. And they may have some bronchodilator effect as well. Steroids are the classic anti-inflammatory medication. They reduce airflow obstruction by reducing airway inflammation in the bronchioles. They also modify the body's immune response to various stimuli. They suppress cytokine production, airway eosinophil recruitment, and release of inflammatory mediators. So the inhaled corticosteroids provide local therapeutic action with minimal systemic effects, although there still is some absorption from the inhaled steroid. Leukotriene modifiers act on inflammatory mediators of asthma, and these may be used as an alternative to the inhaled corticosteroids, although their anti-inflammatory effect is not quite as pronounced. It's often used in patients with mild, persistent, or aspirin-sensitive asthma. The effect is weaker than the low-dose inhaled corticosteroids, but the corticosteroids have major side effects, and so long term in certain populations, especially in children. And they are used as add-on therapy in leukotriene receptor antagonist. This is ferlucast or accolate, and montelukast or singulair, and one leukotriene synthesis inhibitor, xylutone, brand name Zyflo. Leukotrienes produce many pro-inflammatory effects, including smooth muscle constriction, neutrophil aggregation, increased vascular permeability. So inhibiting or blocking those effects is important in the treatment of COPD and asthma, as well as in allergies. Leukotriene inhibitors, ferlucast is metabolized by the liver, so there are significant cautions if a person has liver disease. Montelukast is probably the most common of the leukotriene inhibitors in use, and the brand name for that is Singulair. Oftentimes we're trying to reduce corticosteroid use by switching to a leukotriene modifier, but we need to do that cautiously because there have been some acute exacerbations that have been provoked by stopping the corticosteroid and switching over to the Singulair. Neuropsychiatric side effects can occur on all three of the leukotriene inhibitors. Montelukast can be prescribed to children aged 12 and up. It has fewer side effects and drug interactions, and it can be prescribed once a day and taken without regard to food. And montelukast is also much less expensive